Oh, you went first.
I wanted to.
Okay.
I
Hi, Rebecca. Thank you.
I'm a quick draw.
That's a heavy burden on me to have to start these, so I'm glad you kind of took the reins.
You sound very sultry.
I know. I'm recovering, but I kind of like the way it makes me sound. I'm more
you could
like
be a DJ.
like Batman. All right. Well,
We're gonna finish this managing the adult airway with part 4.
Well, let's not necessarily finish it, because if we go on too long, we may add a part 5. We have just for you listening, we have our whole presentation out, but we don't want to make them too long. So once we go too long, we cut and then turn it into another section, so you don't just sit and listen to one 10-hour airway lecture.
Because we sympathize with our friends who have ADHD.
Yeah, that's true.
So.
All right. Let's go.
We're going to jump right in. This is our section on RSI, and it refers to rapid sequence intubation.
Where's Rachel? Sorry, I just wanted to say that. Where's Rachel? I'm Batman.
But Josh, when we say rapid sequence intubation, does that mean you're putting the tube into her ass?
Oh my gosh, this is one of my things. I learned this from Jason Cook. Rapid, because he had an experience in an ER.
Yeah, if you don't know Jason Cook, he's kind of an airway guru.
Yeah, he's an airway guru in Utah, but he speaks nationally. And anyways, they were RSIing a patient in the ER. He was a flight medic, and the doctor was like, "You're taking too long," and the patient was still oxygenated because they'd done a really good job of pre-oxygenating him, and he's like, "No, he's fine. He's still good." And he's like, the doctor's like, "No, rapid sequence intubation means rapid sequence intubation. You got to hurry and intubate." and so Jason makes it very clear. The rapid part of rapid sequence intubation, or rapid sequence induction, as some people say, is not hurry and get him intubated. It's simply how you push the meds. In dead people, right, when we're working an arrest and we're pushing amps of epi and amps of whatever, we slam them. They're dead, right? It's fine. Magnesium
we want it
in
to hit
torsades, we slam it. In live patients, there are very few times that we slam meds. Like the one that maybe many of you have done, it's in our protocols, is adenosine. That's a med you slam. I once was in the ICU, and I had a traumatic brain injured patient, and the neurosurgeon was in there and the trauma doc, and they wanted to kind of see his response to some hypertonic saline. And so, you've all probably heard of and used 3%, but back then, and I don't know if we still do today, in the ICUs, I haven't seen it on the helicopter, is 23%. And they have different concentrations, but 23% comes in a little syringe that looks like just a little 10 cc flush. And so anyways, we've got the bolt in, so we're looking at the live ICPs, and the doctors are on there, and they're like, "All right, go ahead and push the 23%. And so salt water.
Push it.
How bad could this be? So I just slammed it in, and all of a sudden, like, the dude's pressures tanked, and all the alarms started going off, and the ventilator started. Everything went bad, and they all looked at me, and I'm standing here holding this empty syringe, and I'm like, they're like, "What did you do?" I'm like, "I pushed the 23%, like you said," and they're like, "Well, don't do it like that." And then afterwards, I talked to the trauma doc. I was like, "Why did it do that?" He's like, I'm like, "I pushed it fast. I mean, it's just salt water. Shouldn't do it." I said, "Why does it do that?" And he's like, "I don't know, but I wouldn't do that anymore if I were you." So you don't slam meds. You slam adenosine, and you slam the intubation medications, the induction agent followed by the paralytic agent. That's the rapid, and that's the sequence, rapid sequence. Induction, paralytic, boom, boom, rapid sequence.
One right after the other.
Yeah.
And on a side note, if you're giving medications to a live patient, this is one of my pet peeves. Josh, I just have to take a side note here. And I see providers in the IV line, they pinch the IV line and then in a
above
above
the
it.
port.
And then they slowly push the med in that port.
The,
and then they
the
just,
1 cc's.
yeah, and then they release the line and it just hits them all at once. And I'm like, yeah, pinching it didn't really make it, like it defeated the point of pushing it slow.
You actually, I mean, depending on where you're at, most meds aren't going to reach the patient. You know, you can look on the tubing. It tells you how many cc's fill the entire
the
IV
little
tubing
yes,
set.
yeah.
Yeah, so you can push it fast because there's always a little air
And
bubble
it
there. I
mixes
just push it and watch where the bubble goes, and well, that's one way, I guess. And then set the drip to go in slow.
Yeah, because it's mixed in the line.
But you're talking about mixing it where let it flow.
Yeah.
And just slowly push it. Yeah, for a second while you increase the pressure with pushing that plunger for 1 milliliter or half milliliter. Yeah, the drip will stop. But as soon as you stop pushing, then the drip continues.
Yes.
And then you push a little more and a little more.
Yeah, it's a nice, smooth way to
Yeah.
it's all your pain meds. I do it with almost everything.
Yeah. It's always better to get it in them slower, and that's
Unless
the best way
it's
to do it.
adenosine or you're treating torsades like a fatal rhythm, then we want to get it fast. But generally, that's just public service announcement right there. Okay.
Just one other thing. We'll slam calcium chloride. It comes in an ampule.
Mm-hmm.
We'll slam that in a cardiac arrest. If you slam that in a conscious breathing patient, you're going to send their blood pressure to high heaven and give them a stroke because it immediately increases their blood pressure.
It's active immediately.
So, like, if I'm pushing calcium chloride on a live patient, I'll take like 10 minutes to give them the whole thing.
Which is appropriate. And I feel like this is where nurses that have worked in ICUs and ERs have a corner on this because they know that this is a thing. Our field medics, everything's done like, I always use the reference, but like we're like quick draw cowboys.
Yeah,
So
she's shooting from the hips again, folks.
Yeah. And I just think we need to step back and have a little temperance and yeah. So anyway,
so there we go. Rapid.
Rapid is the administration of the induction and then the neuromuscular blocker or the paralytic. So that is what is rapid about it. I like the fact that they say rapid sequence induction because that kind of helps people
that changes it because it's not the intubation, it's the induction. It really is more what's the word for nomenclature? It's not a misnomer. What's the opposite of a misnomer? Accurate.
It's more
that paints the picture of what's the rapid.
Absolutely.
You're rapidly inducing.
Medication facilitated airway management also gives a better picture of
MFAM.
Yeah, because
which that sounds cool. We could say MFAM. Let's go ahead and MFAM.
Right, because that makes us sound more like we're using a very systematic approach, albeit very consecutive, quick pushes of medicine. That's really all that is. So, the -1A airway. This is a term that I feel like was important to put in because you'll hear people talk about it, and it really applies to RSI. In the Walls manual and in these airway texts, they use this to say you've got the optimal outcome with your airway attempt. So it stands for definitive airway, sans hypoxia and hypotension in one attempt. So if you get
say that again,
definitive airway, sans hypoxia, hypotension in one attempt.
What's sans?
Without.
Latin?
It's without.
That's S with the line over it. One of the abbreviations we use in the hospital.
Yeah.
Without.
Yes. Yeah. So
C with a line over it is with.
Yeah.
Oh, okay.
So, but if you're hearing this or people are throwing this term around, make sure you understand what it's referring to. If we're intubating someone who is clinically dead, this doesn't apply because we're not. They don't have a blood pressure. And their oxygen is probably not good anyway because they're in full arrest. So this is taking someone who is oxygenating fairly well and is maintaining a blood pressure, and we're removing their ability to breathe, and then we did it without causing any deleterious effects.
I like that.
So let's talk about the indications for RSI. And this is different than indications for intubation. Indications for RSI means you have a conscious or mostly conscious patient.
Not nearly dead. This is true. It is very often a conscious patient, but and I'll just throw this in right now really quickly, but sometimes, like I just had the other day, where we had a patient who was a Glasgow of 4, and he needed his airway protected. And so, do we even give him any induction agent?
Does he need it?
Well, we don't know exactly what he's aware of, and he had some liver problems and stuff too. So so in that case, to not give him too many meds that like push him over the top, we halved the dose of ketamine that we gave him,
Which I think is appropriate.
which was reasonable. But
Yeah.
if you have a Glasgow 3 patient who meets RSI criteria, I mean, there may be times where, because it really is the induction agent that can really mess with their physiology, and so sometimes in certain patients, you actually, in the RSI process, it's not RSI, it's just paralytic eye.
Mm-hmm. And maybe some analgesia.
Yeah, sure.
Like
just,
some fentanyl, because it is a painful thing to have a tube.
And there, even without consciousness, there is a pain response that your body will have, which will, send your brain, hey, this hurts. And pain has a negative physiological impact on us.
You can see it in their heart rate, their blood pressure, their tearing.
Yeah.
They might be a GCS3, but their body feels that happening. So I feel it's good to just.
But if their physiology won't tolerate it, then sometimes you just have to. And this is definitely the exception, not the rule. But just throwing out there, and we'll talk about that more. They're not all these patients are going to be conscious, but a huge proportion of them will be conscious. And when someone's looking at you and breathing, and you're about to take that away, it's a big deal, and it's scary, and you need to maintain a high level of respect for that throughout your career.
Yes, because we could kill someone. That being said, blood pressure should not be just counted on to be maintained through pain. Like, I don't want people to think, well, like that'll help keep their blood pressure up. But that's a topic for another day.
Yeah, let's try some experiments on you and see how you like that.
Yeah. All right. So the first question we're going to ask, is there a failure to ventilate or to oxygenate? And this could be for another number of reasons. And they're separate things. Sometimes they go together. Sometimes they are having a failure of both. But sometimes it is that they're not able to oxygenate well, and but they seem to be ventilating okay, or the problem lies with their ability to ventilate.
So an example of that is we had a motorcycle versus wall, and he had massive pulmonary contusions, and we were picking him up from an ER, and we got there, and he could ventilate. He was conscious, like he was moving air just fine, but as that contusion spread and progressed, and involved his alveoli, capillary membranes, he could not oxygenate. And so that was an example of someone who could ventilate, couldn't oxygenate, and so they bought themselves a tube.
Yes. Yeah. So be acutely aware of that. Ask yourself that question. And then, is there a failure to protect the airway? And we kind of described the difference between patency and protection at the very beginning. So can they protect their airway? And if you recall, it was, can they cough or swallow on command? That is really the gold standard for saying, yes, someone can protect their airway. A gag reflex in a relatively unconscious patient does not mean they can. It just means they're going to give you a warning that it's coming. I think the gag is like, oh, we're about to have a problem.
Shower.
Yeah. So that's something that to be acutely aware of.
And the one thing I like to it helps me remember the difference is an OPA and an NPA will maintain a patent airway, but it will not protect your airway. And so that just very clearly highlights the difference between protection and patency.
So not to trail off on another story, but when I worked at the ER, a patient was brought in. I don't even remember what the full complaint was, but he was unconscious with an OPA and they were ventilating him with a BVM. And the doctor that was working that day, he's still one of my favorite doctors that I ever worked with. And he, the patient came in and he wanted to intubate the patient. And they didn't push meds because this patient was being ventilated with an OPA and he just wanted to secure their airway. So he stood up at the head of the bed. We're all there helping. I think I was starting an IV. And as he removed the OPA, this guy vomited so violently it hit the ceiling of the trauma bay. It like showered. We all stood in frozen like terror as this vomit rained down on all of us, and it had
That's like the Green Mile when he vomits the flies.
Yeah, it had hit this doctor square in the face, square in the face, and he had goggles on. I'll never forget because they were like covered in vomit.
You need like swim goggles to protect you from that.
But he stood there like he had the laryngoscope blade in his hand and the OPA in the other hand, and he sat there we were frozen. It felt like seconds of just frozen time. But then he licked his lip and he goes, I think he ate pizza.
Oh my gosh.
And I
love that.
I will never forget that because we were all just mortified and he kind of just turned it into like funny, but whatever. Okay. The expected clinical course, as far as knowing where this patient is headed, and it doesn't mean, oh, they're going to go to the OR. We for sure are going to take their airway. It is, I have a 25-minute transport. They are for sure headed to the OR. I'm worried during this time that we might have an event that would make things worse for this patient. We're going to manage it. And I feel like that's, when you're thinking of the expected clinical course, it's not just like, well, they're going to the OR, so I'm going to put it in.
Right. They're going to get a tube eventually.
Yeah. That's not really the mentality behind this.
And that brings to mind the obvious expected clinical course of like a burned airway, right?
Oh,
where it's
absolutely.
swelling, and you're going to lose the opportunity to put a tube in.
The risks of RSI and required training. Here is where I think most of our problems that arise with RSI stem from, is that the risks are not recognized and the training has not been robust enough to help providers have the confidence and the awareness that they need. So let's talk about risks. The increased ICP. If they have increased ICP, Josh, how does that make it a risk?
Well, there's a couple things. One, especially in like children, right? The vagus nerve runs right along inside the throat there, and putting a big blade, and it's very prominent in the kids, because everything's smaller, so it's in a smaller space. So as you stimulate that, for one, you can stimulate bradycardia, and someone with increased ICP, they need increased MAPs to maintain perfusion to their brain, and the MAP is maintained by having a blood pressure, right?
Yeah, you don't want to
and having cardiac output. And so part of the cardiac output equation is heart rate times stroke volume, and so not part of it, that is it. And so you decrease heart rate, you decrease cardiac output, and you thereby decrease MAP. And so now you could be underperfusing the brain. Then the other thought is that with that pain response, because like Rebecca said, it does hurt, they actually will get a spike in ICP. You get hurt, and just think about it. Like, you scream, like your arm gets, I've never had my arm cut off, but break your arm. I've never broken my arm either, but the pain that surges, that adrenaline rush, right? It doesn't just increase your blood pressure, but it increases pressure in your head.
Which we don't want to do.
Which is, they already have an elevated ICP, and now you put it higher. So they used to say, we don't do this anymore, but they used to just pre-medicate was one of the P's of the 7 P's. They took it out and added pre-intubation optimization, but pre-medicate was give them lidocaine. They thought that blunted the increased ICPs with intubation. Yeah, but they found that doesn't. So if you hear that in a book, that's old school. We don't push lidocaine to blunt the increased ICP response. And so some things that you can do to blunt that is, and this was part of the pre-medication too, which you still can do, is push a little fentanyl.
Yeah.
And give them some pain management.
And
then
analgesia.
Yeah, and then we don't do it as a pre-medication really anymore, but in kids also was atropine to prevent the bradycardia. But when you push atropine before you intubate, now they may be getting bradycardic because they're getting hypoxic, and you may miss that. So you have atropine close by for if
any
you need to
vagal
use it.
stimulation that you might have caused.
Right, but it's not a pre-push med. So yeah.
And we need to remember, I believe it was the EPIC study that came out of Arizona that talked about pre-hospital providers with head injuries. And the
providers with head injuries?
No, providers treating head injuries. Thank you. Treating head injuries. And they found that even one episode of hypoxia or one episode of hypotension can double the mortality of these head injured patients. So they call it secondary brain injury. Yes. So if we give them that when we're RSIing them, we didn't really help them. So if their SATs drop to below 90, that was the threshold. And if their systolic pressure, I actually don't have the study in front of me, but if it drops, it is the same effect on mortality. So we need to have that in our head that we could create a bigger problem than this patient has. So increased ICP is definitely a huge risk.
Just to kind of put in perspective, in the ICU, in a trauma patient with the TBI, once we've ruled out bleeding and stuff, sometimes we'll put them on a pressor just to keep their map
to
up
maintain.
To maintain that cerebral perfusion pressure. So that's how important blood pressure is to preventing brain injury.
Yes. So airway trauma, and I know we work in the realm of just an uncontrolled, chaotic situation very commonly, but airway trauma is handled when they handle it by physicians. They usually lead with a flexible endoscope to visualize what's going on, clear down into the airway. We don't have that luxury. So we just need to be aware that if there is airway trauma, we have the potential to put that tube in a false lumen and absolutely just not even have it where it's supposed to go. So we need to be very, very cautious and careful about that. And then unrecognized, misplaced intubation. And we've all heard the news stories of when patients died because the tube was in the stomach and nobody recognized it. That is a terrifying situation.
Yeah, I've got to tell this story. I may have told this in other places in the course, but when I worked at the flight agency that I used to work at, we had this physician. She was an ER physician down south, and she came and shared this story with us to kind of help us appreciate the magnitude of our responsibility in managing patients' airways. So her husband actually at one point was the Marlboro Man. He was the guy they used back in the day to advertise their cigarettes. Yeah.
Oh my gosh.
And he owned a big ranch down in southern Utah. And one day he was out. There's a cool article. He spent a day with Robert Redford. May he rest in peace as well. Spoiler alert. Marlboro Man dies. But there was his ranch down there, and he had his private pilot's license, and he'd fly his little plane around to look for his cattle, right? And anyways, he crashed, and but he survived, and his all his, we call them cowhands, right? They were all there,
ranch
right? And
hands.
They found him and propped up a saddle behind him, and set him up just like an old cowboy. And he could breathe sitting up, but he was so broken, and his ribs were broken, and who knows what kind of bleeding he had.
Oh.
He couldn't breathe laying down. And so the flight team gets there, and they assess him, and they're like, well, we have to lay you down. He's like, I can't breathe laying down. And they're like, well, you can't sit up. Like, you're a trauma patient, right? Full spinal precautions. So they decided to RSI him so that they could lay him flat. And so they did. They RSI'd him, put him in the helicopter, fly him to, I won't say the place, but when he gets there, they had misplaced the tube and it was in his esophagus. And they killed him. The trauma didn't kill him. The flight team killed him. And she came and told us the story, like heard it from her mouth. And I'll never be cavalier about RSI after hearing what happened to them. I cannot.
My guess is these are not brand new providers either.
Not if they're flight personnel, right?
Right. This is something that you should all be aware of, that it does not matter your experience level, but if you start to be cavalier or complacent in your management of airways, you put yourself at risk for doing this to a patient. I had no idea. The Marlboro man.
He was murdered.
He was murdered.
You know, Dr. He does the MCRIT podcast.
Oh.
Weingart.
Well, thank you.
Dr. Weingart.
How did we forget that? Scott Weingart is like
Yeah, Scott Weingart. He calls the laryngoscope blade a weapon.
It is.
Right?
It could be.
I love how he uses that to let you know. Like a gun can be a tool and it can be a weapon, right, at the same time. And so is a laryngoscope blade. And so I think we just can't emphasize enough the responsibility that comes with the protocol and the go-ahead to RSI patients.
Yes. So, and then we have to have a lot of training, constant practice, strong working knowledge of the pharmacologic agents that we're using, and just well-defined and followed protocols, because the protocols are there to kind of give us it's like the bumpers on a bowling lane, like to keep us safe so we don't completely go off the rails.
Yeah, and I've talked about this before, but pilots, no matter how experienced they are, they physically look at their checklist right in front of them every time they start up on the rotor and on the fixed wing as well. And for us as providers, part of the protocol really should be a pre-intubation checklist that we go through and make sure everything is set up, everything is prepared, here's our plan, right? So that we don't get caught with our pants down.
And everyone on the team should be aware of that list and know it. We generally at our agency, the captain reads the list out loud. And that's just how we practice. But anyone on scene can be the one who verbally reads the list out loud, and we check it as we go. And I feel like that's an important thing. Okay, relative contraindications. Now, by relative, it doesn't mean, we're not going to manage their airway at all, just let them die. But you might change your approach based on some of these things. So the anticipation of difficulty that we talked about earlier, and that's all part of your planning. If the patient has anatomical features that are going to make it difficult, you're going to account for those with the blade you choose, all of your backup devices, and your sequence of meds and everything. The physiological difficulties, you have pharmacology that you can help manage that, positioning, and all of the ways that you prep and plan is what we're talking about. And then unable to oxygenate, that's a big one. If they're unable to oxygenate on their own, how are we going to oxygenate? You need a plan for oxygenation regardless of how you manage their airway. I think you need to have an understanding of what the physiology that's happening so that you can account for it. Would you add anything to that, Josh?
Well, one thing just to go along with relative contraindications is relative indications. Like just because someone does meet the indications doesn't mean it's the best thing for them.
Right.
I had an experience once where, so we had gone on this patient. I don't even remember the patient, but I remember, they could have used an airway, but they were okay while they were with us in the helicopter. We get to the ER and they immediately intubated him, which was fine. But then I'm like, they probably think I'm an idiot. They probably think, why didn't these guys intubate them? And so then I was like hypersensitive to not bringing in a patient unintubated that needed intubation. Well, so then I'm on another flight, and this time we have a brand new flight medic, and then the orienter flight medic, and myself in the back of the helicopter. And so the way we were set up, the medic sits in right behind the patient's head, and we're transporting this polypharmacological overdose patient. He's taken multiple things. Narcan's not waking him up, but he's breathing on his own. And he's doing fine. And, we're 20 minutes out from the ER. We're crammed in the back of this 407. The orienter across from me, because he's letting the orientee sit in the medic seat, right? Mm-hmm. And so, anyways, we're tracking this guy's end-tidal, and it's slowly climbing,
because he's hypopnic.
He's just slowly, his ventilatory drive is just slowly starting to decrease.
Wane, yeah.
So, right, he's 40, end-tidal 44, and then a couple minutes later it's 45, and then it's 47, and it's just slowly going up, right? So it's like, I'm like, I don't want to bring in an unintubated patient again that needs to be intubated. And my partner felt the same. We're like, let's RSI. I'm like, perfect. Well, the back of the helicopter is tight. There's not space to maneuver in this particular helicopter. And we've got a brand new, he's a medic, right? He's been a medic for his EMS fire agency for years, but he's a brand new flight medic. Mm-hmm. This would be his first field RSI. And so we're like, let's do it. And so we do it, and he couldn't get it.
Oh no.
He couldn't get it. And then I'm sitting next to him, and I reach over and try to get it. I'm not in the perfect position, and I can't get it. And then, so we end up having to bag him, and he desatted and all this stuff. We simply could have just mask ventilated him just fine with assisting his own ventilations. And we had 20 minutes, and then, it would have been one thing if it was my regular medic partner across from me versus, but this was a situation where maybe he can wait 20 minutes.
Right.
And we should have waited 20 minutes. And so just because, I would call it relative indications, right? We got to be careful. Just because we can, is that what's best for the patient, right?
Right. And I think that touches on another point is, who is your team you have with you at the time? Because we all know that there's the team that we usually work with that we're very solid with. But if you're with people, either someone brand new or that can change how this process goes. So you need to be aware of that, because you might be giving direction to someone who's not familiar with what you're doing, and that can have issues creep in. So being aware of that.
The guy, we did get his oxygen up, and we got him to the ER, and they intubated him in there, and he was fine. He recovered and went home. I looked at his records after.
Well, and
he
that's
left.
good.
But
That's good. It's just, though, you don't ever want to be in that situation. And then their intolerance to apnea. If you remember the chart, we're going to show it again, of how long a fully oxygenated person has till they become hypoxic. And that changes because they might be completely intolerant to being apneic. So being aware of that.
So the apnea part of it, in this, what I'm thinking of here with this bullet point, is someone who's severely acidotic.
Yes, and you create apnea.
It's not even an oxygen thing, it's a ventilation thing, because by creating apnea and then not adequately ventilating them while you wait for them to become paralyzed, and their CO2 climbs, and they go into severe respiratory acidosis. They're already on the line, and then they arrest.
You've taken away their compensatory mechanism for that metabolic acidosis, and you're tipping them over the edge.
Yeah, so if you're not going to be able to mask ventilate this patient safely, then that would be a relative contraindication.
Yeah. And acidosis is one of those things that is listed under that high consumption umbrella because
of crash.
Yeah. So keep that in mind.
We're going to go ahead and break there because we've been going on, but I feel like the information we've been providing is useful. So I don't feel bad.
Part 5.
I don't feel bad, but yeah, we're going to move on to part 5. So go to the bathroom, get a drink, relax.